are because of the X-ray views. X-ray views are known as Judith views. All right, X-ray views are the Judith views. But before we talk about this Judith view, as I told you, the key term in having a discussion of the acetabular fractures in orthopedics is the word Judith. So whenever you see the word Judith in any of your question which is related to orthopedics, possibly they are asking about the acetabular fractures. Now let's have a discussion on these X-ray views. All right, now let's just have a look at this picture. This is the X-ray of the pelvis including both hip and with the acetabular fracture which is extending all the way up to the iliac wing. All right, now when there is a fracture in the acetabulum, it is not confirmed whether it is involving the anterior column or the posterior column. In order to have the basic confirmation, in order to get the basic alignment of that where exactly the fracture line is involved in the acetabulum, whether the anterior or the posterior part, you have to manipulate the patient and the X-ray projections. So those manipulations are known by the name of Judith view. So this is simply the anterior-posterior view, and in this anterior-posterior view, as you can very clearly visualize that there is a fracture line visible over here, but we are not very much sure that where exactly this fracture line is, whether it is anterior or posterior. So for that we are having the Judith views. So what actually are the Judith views of the acetabulum? Judith views are basically divided into two. One is obturator oblique and the other one is iliac oblique. So obturator oblique and the iliac oblique. Now if you talk about the obturator oblique, it is obtained in, means what is the position in which the patient is kept? The position in which the patient is kept is 45 degrees of internal rotation. All right, while the iliac oblique is obtained when the hip joint on the affected side is in 45 degrees of external rotation. Now just try to understand. Imagine there is a patient who is lying supine on couch and the X-rays beam is projected from the superior aspect. So this is vertical projection of the beam. If the right hip is affected and the patient is inclined like this, where there is a 45 degrees of external rotation of the affected hip and then it is projected to a beam, it will be a iliac oblique view. On the other hand, if the patient is shifted like this, where there is a 45 degrees of internal rotation of the affected hip and then it is projected to a same X-ray beam, it will be obtained in the 45 degrees of internal rotation known by the name of obturator oblique. Now, why is it called by the name of obturator and the iliac oblique? Just try to understand by looking at this image. Now here, the right-sided hip image is obtained by placing the patient in 45 degrees of internal rotation and the entire obturator foramen is clearly visible. That is the reason why it is called as obturator oblique. On the other hand, when the same patient is or the X-ray is obtained by external rotation of the hip joint, then the entire iliac wing is clearly visible. That is the reason why it is called as iliac oblique. Now comes the question that what is the use of having this obturator and the iliac oblique views? The use is that in the obturator oblique, you tend to see the anterior column and the posterior wall. It is the visualization on the basis of which we tend to see the fracture line which is involving the anterior column or the posterior wall of the acetabulum. So these are the structures which are very clearly visible. Again, back to the X-ray. Now, if you look at this here, the iliopectineal line, that means the anterior column of the acetabulum, is very much clearly visible over here. That is the reason why obturator oblique is required for the visualization of the anterior column and the posterior wall to some extent. But this iliac oblique view, that means 45 degrees of external rotation view, the structures which are visualized are the anterior wall, but the posterior column. So the structure that you tend to see over here is the posterior column. So posterior columnar fracture are identified on external rotation. Anterior columnar fractures are identified on internal rotation. This is what the gist of this question is. All right. So here we are getting the better view of the posterior column of the acetabulum. This is what was the essence of the Judith views are. That was the modification of the X-ray of the pelvis, including both hip, in order to identify that where the fracture line is. Now you will ask, why is it so much required to have the basic identification that whether the anterior or the posterior column of the acetabulum is affected? All right. The reason is that imagine if there is a fracture in the anterior column and you try to fix it by surgical approach. So you have to take the anterior approach. That means ilioinguinal approach will be required in order to open that anterior column of the acetabulum. Imagine if you have opened up by the Cocker-Langenbach approach, that means the posterior approach, and then by opening the entire acetabulum, you recognize that there is no fracture in the posterior column. All right. So before putting the patient on the operative table, you have to know that where exactly the fracture lines were. Now you will ask, is there not a sophisticated investigation which is available in order to delineate that where exactly the fracture is? Yes, today the fractures are very clearly visualized on 3D reconstructed CT scans. But these X-ray and their importances are also important for you to remember, and their significances are important for you to remember also. All right. So today the investigation of choice is the CT scan, because you can get the 3D reconstructed images of the entire acetabulum, that where exactly the fracture line is, and you, on the basis of that, you can decide your approach on the operating table. Hopefully you have everything is clear related to this particular topic, and the importance of the word Judith, as I told you repeatedly, that Judith is important because of two reasons. One, he gave the classification. Two, he gave the X-ray views. All right. So investigation of choice, already you came to know, it is a 3D reconstruction of the acetabulum on CT scan is the investigation of choice. As far as the approaches for the management of acetabular fractures are concerned, as I told you, if the anterior column is affected, so ilioinguinal approach is anterior approach is ilioinguinal approach. All right, a 3-window approach, ilioinguinal. While most of the time it is the posterior column which is affected, so the posterior approach is the Cocker-Langenbach approach. And all of you are aware, means it is not something which you are not aware of, that if you open the hip joint by the posterior approach, then the name of the structure which is likely to get injured is the sciatic nerve. While if you open it from the anterior aspect, then there are multiple structures which could be affected, right from the inguinal ligament, the structures which are present inside that, femoral artery, the femoral nerve. So there are multiple structures which could be affected. But this Cocker-Langenbach approach, the most common structure which is injured is the sciatic nerve. So it is the posterior approach for the fixation of the posterior column fractures of the acetabulum. All right. So hopefully everything is clear related to this particular topic, that is acetabular fractures. Okay. So as I told you, the word Judith in particular is very important. You need not to dig too much into the details of the acetabular fractures. All the things you need to have a basic overview is that at least you should know that which column is affected because of this particular fracture. So this much you need to understand. Next question is, or next topic is the fracture head of femur. You know, this topic in particular is important because of its classification itself. Means you need not to go too much into the details of that what exactly the fracture head of femur is. The name of classification itself is important, as this is the question which they have asked in 2012 examination, and since then not even a single question has been repeated. But what is Pipkin classification? So by a rough diagrammatic representation we will be talking about this Pipkin classification. The name of the classification is Pipkin, and by a rough diagrammatic representation we will be talking about this Pipkin type of the classification. All right. So imagine this is the head of the femur, this is the greater trochanter, this is lesser trochanter, and this is acetabulum. All right. We are talking about the fracture head of femur. Now in the center we are having this structure which is known as fovea, and this fovea is providing an attachment to the foveal ligament. All right. So in the center, the name of the structure is fovea. And if the fracture line is related to the fovea, which has been classified into different types. Now, what all are the different types of the fractures that can happen is type 1. Now, in type 1, the fracture line is infrafoveal. That means if there is a head of the femur fracture, which is below the level of the fovea, it is type 1. Then, if there is a fracture line which is above the level of fovea, it is considered as type 2. So obviously, which one will be having poorer prognosis? Type 2, because it is directly involving the weight-bearing surfaces of the head of the femur. But if there is a fracture line which is involving the head of the femur in both the columns, that means transfoveal, it will be type 3. So type 3 is transfoveal involvement of the head of the femur. So obviously, out of these three, the type 3 would be having the worst prognostic outcome. And then finally comes the type 4. Now, in type 4, if there is a fracture head of femur, but this fracture head of the femur is also associated with either fracture neck of femur or dislocation. If there is a fracture head of the femur or there is a dislocation associated with the fracture head of the femur, this is the type which is obviously going to have the worst prognostic outcome. So out of these 4 different types, the best prognostic outcome is with type 1, while the worst prognostic outcome is with type 4. So this is all what you need to remember in fracture head of the femur. That is name of classification, Pipkin's classification. All right. So you need not to go too much into the details of this Pipkin's classification in particular. Next, a very, very important topic for us to know about is the fracture neck of femur. Now, before we talk anything related to this particular topic, fracture neck of femur, before even we talk about the classification, the clinical features, the age involved, the mechanism of trauma, the treatment protocols, before we talk anything related to it, it is important to have a distinguishing feature, or it is important to have a discussion of the complications related to fracture neck of femur. All right, because even if we tend to decide the management protocol for fracture neck, it will be based on complications. So everything is based on the possible complication, that with this, what is going to be the rate of complication? With this, what is going to be the difference in the complications or in the prognosis achieved? So it is always important to have a discussion of the complications first in fracture neck of femur. Everything is going to be related to the complications itself. Now, for the first complication, which is very clearly visible over here, is the osteonecrosis head of the femur. All right. As far as complications of the fracture neck of femur is concerned, one is osteonecrosis. All right. Now, what is osteonecrosis? This is an entire topic that we are going to have a discussion on. It is avascular necrosis head of the femur, but this osteonecrosis is considered to be the most common complication related to fracture neck of femur. All right. Next is non-union at the site of fracture. So you see, this non-union is a prevalent complication in fracture neck of femur. It is a very common complication in fracture neck of femur. Every time you see a patient who is coming with the fracture neck of femur, all the management protocols are decided how to limit the possibility of non-union. All right. So the question is that why non-union is such a common complication in fracture neck of femur. So there are 3 reasons attributed to this. The first reason is precarious vascularity. You know, as far as vascular arrangement to the head and proximal neck of the femur is concerned, it is not efficiently vascular. It is deliberately or relatively non-vascular structures. So if there is a fracture, because of precarious vascularity, the possibility of non-union is increased multiple fold. Second reason is that intracapsularly, there is a presence of the intracapsular enzyme, that is hyaluronidase. You know, this intracapsular enzyme, that is hyaluronidase enzyme, and the action of this enzyme, you know, the action of this enzyme is that it breaks the clot or hematoma. It is responsible for the breakage of the clot or the hematoma. That is another reason for the non-union. Now, how this break in the clot or break in the hematoma is progressing the fracture neck of femur into non-union We will come to know after some duration of time. At this point of time, you just remember that intracapsularly there is a presence of enzyme which is responsible for increasing the incidence of non-union in fracture neck of femur. And the third reason comes is that the neck of femur